for this webinar. So with that, resume recording here. Okay, so with that said, I also want to inform that we obtained the approved CE, continuing education, for this 1 hour. So instructions how to submit and to claim that CE will be provided at the end of the presentation. Now I would like to introduce you to our very first guest speaker, Mrs. Christine Victorian. Ms. Christine Victorian is a registered nurse. Sorry, guys, I don't know why my slide isn't advanced. So Ms. Christine Victorian is a registered nurse who's currently holds a position of a Director of Quality and Patient Safety at Harris Health System, Ambulatory Care Services. She received her bachelor's degree of science in nursing from the University of Phoenix and the Master of Science degree from the University of Texas, Arlington, with a focus on nursing administration and education. Mrs. Christine Victorian's clinical background as a cardiovascular nurse provided a firsthand experience in her caring for patients. So in 1998, after 5 years of clinical setting, Mrs. Victorian embarked on a new journey, devoting over 22 years of in managed care, population health, disease management, and healthcare quality settings. She is a certified professional in healthcare quality from the National Association of Healthcare Quality, and it also a certified managed care nurse from the American Board of Managed Care Nurses. Mrs. Victorian also a member of Sigma Theta Tau International Honor Society of Nursing. In addition, she is a member of American Society of Quality, National Association for Healthcare Quality, Texas Nurse Association, and American Nurses Association. Ms. Victorian was on the board of Texas Gulf Coast Association for Healthcare Quality in the past, serving as a education director. When not pursuing her nursing passions, she enjoys traveling, camping, and spending time with her family. With that, Christine, I am welcoming you to share your experiences with us today.
Thank you, Vivian, and good afternoon, everyone. And thank you for the opportunity to allow me to continue the conversation that we've started about COVID-19. And I think about 1.5 years ago, we were all sitting in a different spot at time. But before I get started with this evening's topic, I wanted to just talk a little bit about my organization, and we're Harris Health System. And it is a fully integrated healthcare system that cares for all residents of Harris Health, Harris County. We are the first one accredited for, as designated by the National Committee for Healthcare Quality for the patient-centered medical home. And we're one of the largest systems in the country to achieve this standard. So we have over 18 community health centers, 5 same-day clinics. We have 5 school-based clinics and 3 multi-layer specialty clinics, as well as 2 hospitals. We are trauma level 1 at our benchtop. It's a 444 licensed bed organization. We also have our Lyndon B. Johnson, which is a level 3 trauma and has about 207 licensed beds. We also serve, provide for both our Baylor College of Medicine as well as the University of Texas Health Science of Houston as the academia for their residents. And we train the next generation of healthcare providers in the latest medical procedures and technology breakthroughs. And with our fully integrated electronic medical record system, we offer patients the convenience and assurance that their medical history is accurate, safe and available when and where it's needed. So our health medical home designated ensures that we offer a full range of service, preventive as well as specialty and acute care services for the entire family. So thank you very much for this evening, and we're going to jump right into our topic. And before if we can move to the next slide. Since this is an education offering, by the end of my presentation, you'll learn about the response to the Center of Medicare and Medicaid, or CMS, also the application of American Telemedicine Association in the development of quality metrics for COVID-19 patients under investigation. We'll also talk a little bit about, monitoring and the plan, how we audit the process, and then share at least one lesson learned from the program that can be utilized for other telemedicine programs. Next slide. So a year and a half ago, we understood that our nation was in crisis as well as the rest of the world. We had the pandemic with COVID-19, and our quality department was tasked with developing and identifying quality metrics for our navigation program, specifically our patients under investigations who were receiving video visits. CMS 1135 waiver allowed that with that expansion of telehealth with that 1135 measure. And under this new measure, Medicare can now pay for office, hospital, as well as other visits furnished via telehealth across the country, including in patients' places of residence. And this was back starting of March of 2020. We also wanted to make sure we were decreasing patients' footprints by limiting the community spread of the virus, as well as limited the exposure to other patients and staff members in an effort to slow the viral spread during that time. Next slide. So when we embarked on this journey to really look at quality metrics for our patients who were COVID-19 and bring that into fruition, there was not very much in the healthcare field specifically looking at quality metrics that were already well defined and delineated. So we, with the great help from my team, we did our research and identified the American Telemedicine Association and their practice guidelines for live and on-demand primary and urgent care. Their 2020-15 guidelines provided us with some foundation to develop these quality metrics. And under the particular guidelines, one of the statements for looking at utilizing their guidelines was providers shall employ a coordinated quality improvement program of clinical oversight process, and that a quality review should be conducted on a periodic basis to identify specific risks and qualify failures. So they stipulated that as part of their requirements, utilizing and given that guidelines if you are formulating a program. And we also look at our key processes for COVID-19 workflow for patients under investigation. We integrated that along with the American Telemedicine Association guidelines. So our next slide talks about the different processes we had in place under the COVID-19. I want to emphasize this was a really focused population, and we were specifically looking at video visits for those patients. So the key processes comprise of a multidisciplinary and multi-department approach, including patient center, ask my nurse, nurse navigators, and physician. And we work very closely with our physician, Dr. Larissa Rich, who at the time was the medical director of that program and really supported the quality team as we develop these quality metrics. So we identify internal quality metrics to measure the program. We looked at providers as well as the program performance, and we developed 6 quality measures for the program, as well as 6 quality measures for the providers. And the current focus of COVID-19 patients' internal quality measures will eventually phase out in the future, but for right now, these are the measures that we are looking at. We move to the next slide.
Oh, there's a, sorry, previous. So this is to stop for in regards to our polling questions. Number 1, if you could answer, put in your answer in the chat box for the answers, then we can capture that attendance here. So the first polling question is, who is the professional association that provides the or published guidelines for the telemedicine? So we take a couple, 30 seconds or so for the chat box. So what we see in the chat box continued in here is, you're correct. It is from the American Telemedicine Association. And the guidelines that Christine referring to was published in 2015. Okay, Christine, continue on your presentation.
All right, thank you, Vivian. And I think something that before I go to the next slide, I just want to emphasize, while this was new and exciting, it was really also very scary because we were embarking on a journey that had not been crossed before. So it was an exciting time, but it was also a little bit scary time as well. So going on to the next slide, we identify, like I say, 6 program quality metrics, and we utilize the American Telemedicine Association to really help us to hone in on looking at what type of devices were people going to use. This is an electronic program. This is telemedicine. What were they using? Were they using computers? Were they using mobile devices? So as we set up these different visits, the provider was well aware of the type of equipment our patients were using. We also look at biometric devices, and that is really looking at what type of equipment patients had at home that can be utilized to help a provider conduct a good physical assessment, even if it's not something that's being done face-to-face, but being done electronically. So did they have blood pressure machines? Did they have a glucose machine? Did they have thermometers at home? We utilize that information. And then one of the things is measuring whether or not you have equipment or any kind of connectivity failures. Very important to ensure that your system is sound, so that during your calls or during your visit, you do not have that interruption. We also identify telehealth referral to MD, were those appropriate or not, based on the criteria that had been identified for which patients should be referred appropriately to the telehealth video visit with the providers. We also looked at our navigators and the telehealth referrals to determine whether or not those were appropriately done. And then finally, on looking at our overall programs, is the Ask My Nurse, which was also another key part of the program, whether or not those patients had to go to the emergency room, were there any 911 referrals for those patients, or did we appropriately have those patients assigned to come into the Navigator Patients Under Investigation program. We also look at the healthcare providers themselves, their care plan. This is the care plan for the providers for the telehealth visit. Also, with the emergency care plan that they identified these patients needed to go to the emergency room, and were those delineated there as well. We also measured patient fallout within 24 hours of enrollment, and that's specifically looking at the navigators. Once these patients were referred to them, did they contact that patients within 24 hours? And then we looked at care plan for the following the ambulatory care services protocol, as well as whether or not the care plans were actually followed. And then later on, as the program expanded, we identified the COVID positive patients, ensuring that these were in our electronic system, were they flagged to ensure wherever they were going for care, people were aware that this was a positive patient. Next slide. So part of developing quality metrics is having a way of auditing to make sure that you are indeed being effective, that the program that you put together, is it being effective or not, to ensure that the patients are receiving safe quality care. So as I mentioned before, we utilize the criteria from the ATA as well as the telemedicine process. And the audit will be performed in the ambulatory care setting. That was identified. It was also specific to COVID-19 patients and under investigations. And it would be the providers who utilize the telemedicine video process during the COVID response. With the auditing team comprised of the quality department in the ambulatory care setting. And we had an effective date of April 20th to start rolling that out. We had a random selection of patients from the medical records, and these patients were part of the Navigators program, and they were identified to be audited to determine whether or not we were in compliance with those 12 quality metrics that we talked about before. So let's see how we did with that program. So again, you know, in our summation, we did it based on response to COVID-19 pandemic. We utilized the American Telemedicine Association practice guidelines. And then we looked at our, you know, over the time period of April last year, 2020 through February of 2021, we did over 3,646 audits with specifically patients who had video visits with our providers. Our 6 metrics specific to telemedicine program, as I said, and 6 to the providers were all evaluated for compliance. And then telehealth contact types assessed during the audit were patient navigators and our qualified licensed professionals as well. We identify opportunities were associated with the access to computer, mobile device. We were compliant at the time, 43.9%. On access to biometric device, 52%. Then absence of equipment connectivity at the time, 99.3%. And appropriate telehealth referral for the QLP was 83.1% compliance, 99.5% compliance for, you know, the navigators following up within 24 hours, as well as 99.4% for the navigator care plan adherence, and then 95.7% of compliance for our positive flag patients. So if we go to the next slide, we'll pause for a moment.
So we're pause for a moment. Thank you very much. Great summary. So this is for polling questions number 2. Would you please answer your answers into the chat box? So how many quality metrics developed for the telehealth providers at Harris Health System? So the answers in your text box is correct, and that there are 6 metrics that was selected for the provider. Thank you very much. And Christine, continue on your results.
All right. So I touched on the results already. Like I said, we did over 3,000 audits during that time period. And really and truly, I want to focus on the number 98%. This is the overall compliance of the program. So, kudos to the navigator team, kudos to the doctors, as well as Ask My Nurse, as well as the patients who were and ensure that patients had appointment, because metric specific compliance was 98%. So next slide. This is a graphical view of how we did over that time period. And I just want to point out on the first one, right now for months March, April, May, June, we are 100% compliance in terms monthly compliance for those, because we met with our providers who really had an interest in ensuring that they looked at capturing that data. We also look closer at, as you can see, the biometric was very low as well. Again, after touching and meeting with our providers, they really had those numbers. Now the last 3 months has been 100% compliance, because they really had an interest in identifying what type of biometric devices patient had at home. And again, we did very well in terms of connectivity, as well as overall the program, like I said, have done extremely well. So without really repeating the numbers that I've already spoke about, just the numbers speak for themselves and how the program has done. Next slide. Again, just a graphical showing that different COVID-19 response, and we can go to our final slide. So what did we learn? Okay, a couple of things that we think can be utilized in other program is biophysical devices, the availability of those. That gives now the opportunity to ensure if we're going to continue with telemedicine programs, which we know we are, because it is now pretty much inducted into everyday delivery of care as another model, that this will be an opportunity for organizations to look at what kind of devices, how can they assist patients. In our organizations, we have our community outreach, case management team, looking at the different devices that's out there, and how can we get those into patients' home. Equipment failures and connectivity is the next one that we know can be shared information. One of the things that for specific to that program, again, kudos to the nurses, preparing the patients, getting the patients very comfortable, so that when the patients and physicians are finally on the call or on the video chat together, that all of these kinks have been worked out. Every once in a while, you do have a failure of the video chats, but we do have it immediately being connected to a telephone visit, so the patient themselves still continue to receive that care. And I do have National Quality Forum as one of, they do have quality metrics that are more of the clinical nature that we would eventually tap into those resources. And of course, you know, COVID-19 is eventually not going to be with us, and neither with those COVID-19 patients. So we have to look at this on a broader scale and look at different quality metrics for our patients and ensure that we continue to provide quality care for them. And that concludes my presentation. Thank you very much, Vivian.
Thank you very much. And did anybody have any questions for Christine? Okay, thank you very much, Christine. I learned quite a bit from your project as well. You know, as we responding to COVID-19, we have to improvise how we continue on that continuity of patient care. I know that many of us, and I'm sure individually, we do experience ourselves that gap in care or access to care. And you know, with your program and the navigators, we were able to continue that care. So it's a great effort in making sure that the patients are still being looked at or being cared for during the time of crisis.
Absolutely, Vivian. And must say, the Navigator team, they've done a fantastic job and bringing this, like you say, allowing patients access into the into care, even when at a time when the face-to-face visits were decreased, we still ensure that patients were able to receive quality care.
And we do have a comment from Tiffany Davis in the chat box here, is that she can't imagine what would have happened to some of these patients if there was no telemedicine. So that was great resonation of that comment. Thank you. Okay, so with that, we are moving on to, everyone wants to have a break or just continue on with the presentation? Continue on with the presentation. So I am going to introduce to you our second honored guest speaker, Ms. Toni Cotton. Toni Cotton is currently our Chief Nurse Officer for Bentop Hospital in the Texas Medical Center. Many of us here who live in the city of Houston know the Texas Medical Center. She's offered a track record of building nurse excellence and patient safety. Prior to her current role, Toni was the CNO of the Ambulatory Care Services for Harris Health System. She joined us in January of 2019. Harris Health System had 2 acute care hospitals and 42 outpatient centers across Harris County. As the CNO of Bentop, Toni has nursing oversight for 402 licensed bed hospitals, greater than 65,000 emergency visits on an annual basis. Bentop is also one of the 2 level 1 trauma centers in the city of Houston, comprehensive stroke center, magnet designated facility, and has the only psychiatric emergency center in Houston. Prior to coming to Harris Health System, Toni served as the CNO at a 302 inpatient bed hospital, where she was instrumental in achieving the pathway of excellence designation, the Bariatric Center of Excellence, primary stroke certification, Gold Mission Lifeline Award, and successfully nursing internship programs, achievements in patient, staff, and physician satisfaction and quality. Tony received a bachelor degree in nursing from Houston Baptist University, a master's degree in health administration from University of Phoenix. She is currently pursuing both of her nurse executive board certification and the doctorate of nursing practice at the University of St. Thomas, where she is working on the suicide prevention. Tony has a passion to help others, and in all her administrative decisions, the patient is at the center of her heart. Tony states that I believe I have a sacred duty to always put the patient first in all of my leadership decisions and always believe the best in others. Tony has 3 children, 5 grandchildren, and lives in Katy, Texas. When not working, she is involved in church activities, enjoys outdoor activities, gardening, and spending time with her family. Tony enjoys daily inspiration from the patients and staff and other staff members who care for them. With that, Tony, thank you for your leadership, your commitment in patient safety, and then I welcome you to share your experience with us.
Well, thank you, Vivian, for that very warm welcome. It was very nice. So we'll go ahead and move on to the first slide. I'd like to share the mission of Harris Health. Christine went over very nicely the overview of our operations, but we are a community-focused academic healthcare system dedicated to improving the health of those most in need in Harris County through quality care delivery, coordination of care, and education. And our vision is to become the premier public academic healthcare system in the nation. So we are a safety net organization. And I'm not going to go over all of this. You can read through it. Christine did a nice overview of our system. And she also gave a nice overview of the hospital. So we can go to the next slide. Where I'm at now, as Vivian was saying, is I'm at Ben Taub Hospital Level 1 Trauma Center. And these are some of the highlights there. I think we've covered this already, Vivian. We can go to the next slide. And this is our other hospital in our system, LBJ, which is a level 3 trauma center, 215 licensed beds, and they see over 66,000 emergency center visits. Next slide. So my role when I was the Chief Nursing Officer in Ambulatory Care Services, when we first heard in February of 2020, the WHO announced COVID-19 has had an official name. And then in March, the first case appeared in Fort Bend County. We immediately, what I'm going to talk to you about over the next few slides is what we did in the days that followed these 2 important dates in our history. The organization that we ensued after this, the leadership, the strategy that we put together very quickly to start to combat this terrible pandemic. The first thing we did was we gathered together a multidisciplinary team. We put everyone on the team that was part of our leadership in ambulatory care services. And our system team, Harris Health, they set up a command center. Next slide. One thing that we noticed is that coping with the fear amongst our employees and our providers was very, very huge for us. There was an unprecedented change in patient care and anxiety amongst our patients. We all had to quickly adapt to a new normal, that bedside care, visitation changed, everything immediately changed overnight. We recognized those that were impacted personally. People started losing loved ones started to get sick, and dealing with all this personal crisis with our staff and our providers was very overwhelming in those early months before the vaccine, of course. Patients continued to rely on us for increased medical and emotional and spiritual care. Our clinics were overcrowded. People were standing at the doors wanting help, and we were always dealing with maximum capacity in ambulatory. We had limited community demand for symptom management and support groups because COVID had pretty much shut everything down. So we're so proud that Ben Taub Hospital stepped up to care for our patients impacted by COVID during this public crisis. The heroic work goes very much recognized, And so what we wanted to do immediately at the very onset of this crisis was set up some coping for our nurses and our providers. So immediately we put together a comfort cart, and that comfort cart had snacks and drinks, and we would take it around to the staff that were overworked and working long hours. We also had the chaplains go and visit the nursing units and do blessing of the hands and pray for the staff. Anyone that wanted PTO, we were very liberal with granting our PTO. A lot of our leadership at the time started to telecommute and work from home. We started many GroupMe and other virtual care platforms in order to be able to communicate in real time. And then we developed a virtual nurses week in 2020, which was very different. Some of our nurses, under the stress of it all, did call Safe Harbor, but we were able to work through that. And then the other thing that we did was we started a what we called Talk Time with Tony, or Nursing Forum, which was for all staff to call in and ask questions. Next slide. The response of our system was also equally as strong. The system team put together very quick the Incident Command Center, where we had a representation of all of the multidisciplines of the system: patient care management, case management, providers, infection prevention, administration. We began to immediately put together how we were going to coordinate this care, how we were going to take care of our patients, how we were going to begin to vaccinate our patients. So Christine talked a lot about telehealth. This is where it all began, with the idea of telehealth. What is it? What does it look like? How do we do it? How do we do it quick? Also, how do we get medications to people at home that couldn't come to the clinics, couldn't come to the hospital, that were homebound? Christine also mentioned the patient navigation system. That was a very strong system where if a person was considered what we call a PUI, or a person under investigation or suspicious for having the COVID pandemic, they were immediately quarantined at home. And then through the telephone and televisits, we were able to keep tabs on those patients and those employees. One of the biggest things I was involved in was the surge plan, and I'll talk a little bit more about that. But that was a massive endeavor to mobilize a small army of nurses throughout all of the clinics and hospitals to take care of these very, very sick patients. The communication strategy also ensued, starting with the CEO down to the CMO. We had daily, weekly calls with our system leadership. We had weekly town halls. And also in our COVID, we started putting together plans to utilize our clinics for COVID vaccinations. Next slide. So right away, we knew that in ambulatory, we needed to develop a communication plan. The overall goal was to vaccinate over 1,000 patients a day, and we had certain sites that could do it. So we immediately started converting clinics into COVID vaccination sites. How could we do that? We have 40 different sites across Harris County. So coordinating 40 different sites, that's 80 leaders, 2 leaders per site. Plus all the administrative and ancillary support team. There were several hundred people to coordinate in a very short amount of time. So we needed a communication plan. So what we did was we put together daily calls. Sounds like a big commitment, but they were well utilized and well attended. We had nursing on the call, operations, we had providers on the call. We had ambulatory daily incident command meetings with executive leadership where we hammered out all the details of screening and how we were going to screen our patients prior to coming into the clinics. Then we had a 12 o'clock check-in call that also anybody could join. And then we also had another call just for the providers. The providers were our resident experts. There were countless questions from the staff and the patients, and we needed our providers to be well equipped and aware to handle the onslaught. We had weekly town halls with our Incident Command Center. We had weekly pavilion emails and updates. And then we developed a nursing SharePoint site to include the COVID-19 page that contained all of the resources in a one-stop shop, ease of access for our clinical team. Next slide. Continuing on with the communication plan, we developed some changes to our schedules. QRC was moved to WebEx. All of our meetings actually were moved to WebEx. We created the My Health mobile video feature for patients so they could check their records online by the way of their phone. This was set up in record time. It's something we have been talking about for a very long time. And one of the great things about COVID is it pushed it forward very quickly for our patients. So we could stay in touch with them and they could stay in touch with us. We started ACS Nursing Weekly News. There were many niche nuances to work out with the nursing team to be able to accomplish this goal. And so we had a weekly newsletter that went out to all of the nurses electronically in addition to our daily calls. We also held Nurse Manager Forum. As you can imagine, the nurse managers were dealing with a lot of anxiety and crisis with all of their staff and dealing with in their face the patients. So the daily forum, we were able to swap and exchange ideas and share best practices, and then just to listen to one another, cry with one another, and just give each other virtual hugs on a daily basis. And then that's when we started developing the clinic workflows. Next slide. Oh.
So Tony will pause it here for the very first polling question.
Okay.
Again, please enter your answer in the chat box. What is the incident command and its role during a public health emergency? Do we get responses? For our participants?
There's one.
Yes, it was part of the COVID response. Yes. So is oh, something is happening here. Uh-oh, what is going on there? So incident command is a standardized approach to the command, control, and coordination of emergency response. So we use this a lot of times when there is a crisis happening. So we have some issues with the screen here. Okay, Tony, we'll resume back to your presentation.
Thank you so much for that. So one of the first things we needed to do was develop a screening program. So across all of our sites, we had to screen everyone walking into the building, providers, patients, staff. So we developed and designed a screening. Who would screen? We soon learned it didn't have to be two nurses, but it could be a nurse and a non-clinician. So eventually we had everyone helping screen. We had security help screen. We had our case management or infection prevention. We had everybody helping screen the patients. But at the very onset, we thought it had to be a clinical person, but we quickly learned having a clinical person immediately available if somebody screened positive was really all we needed. But that was a very long and detailed process to work through the whole screening process upon entry. We had to rebuild our EPIC programs so that it included the COVID screening. We had to train our nurses. We had to train our non-nursing roles. And then we started developing a very new and I feel divine relationship with our pharmacy team during this whole process. Next slide. The next thing we wanted to do was come up with a plan on how are we going to staff all of these clinics. First of all, we had to identify what clinics we were going to have to close in order to take that staff and move them into clinics that would stay open and start giving the COVID vaccine. And so that was a very tough decision. It's very hard when you have community-based clinics that are very loved and needed by the community. When you close a clinic down, it's no small thing. It's actually very devastating. So it was a very tough decision and a very long and analytical decision, but we decided to close City Gas, all of our school-based clinics, Cypress Clinic, Casa de Amigos, and Baytown. The next thing we did after we closed the clinics, we started cross-training all of our ambulatory staff to function in the clinic. teaching them all about COVID vaccine, did the Pfizer training, the Moderna training, the EPIC training. And we also started mobilizing a small army that we were going to have to deploy to the hospital. So ambulatory nurses came off of the clinic, and we started cross-training them to actually work inside the hospital. This, as you can imagine, was a very tall task. It was a very, very challenging task. One of the most challenging things I've ever done as a nursing leader. But we were able to mobilize and train 140 ambulatory care staff deployed to both Bentop and LBJ. And what it was we deployed our ambulatory nurses to be helpers and nurse assists on the med-surg units. Then in the med-surg units, they floated up to the IMU, and then the IMU floated up to help with our ICU. So it was a cascading effect that went upwards. We also were able to get a small group, about 50 nurses, crisis nurses, that came in from all over the state of Texas to help us. We also were able to get a few Project Hope nurses, contract nurses. We offered the nurses high needs pay. We offered them COVID specialty pay, all in efforts to help them overcome this great sacrifice they were going through. The next slide is just a snapshot. I don't expect you to read it, but I want to just share this with you because in order to mobilize all the staff and staff them every day in the hospital and across the clinics that we're going to be giving vaccines, it was about 335 nurses a day we had to coordinate. So how in the world were we going to do that? We went quickly to our internet friends, and we were able to find a program called Sign Up, and we quickly implemented that, tailored it for Harris Health, and then we were able to use the Sign Up app for nurses to go in and sign up for what shifts they wanted at what clinic, so that we could start mobilizing these nurses to the proper location. Now the nurses, the other group of nurses that we trained were what we called admin nurses. The administration nurses were nurses that we pulled out of their offices, and nurses that normally sit behind a desk all day, and trained them to also work in the clinics and trained them to give vaccines. So that was a huge endeavor, very, very rewarding for those nurses. It was scary at first, but after they started doing it, they found it to be very rewarding. Okay, next slide. We quickly learned also that giving the vaccines and setting up programs to deliver the vaccines wasn't enough. We need to also provide testing. Across the city, as you can remember, there were not enough testing sites. The demands for testing way outweighed the supplies for testing. But we went ahead and started testing on our pediatric sites. We started testing in our homeless shelters as well. Next slide. Christine talked a lot about the telehealth implementation. This is something I'm extremely proud of on the clinical side. One of the first things we did was we realized that patients that needed to come to the emergency room may be afraid to come, or maybe they came too often, one extreme or the other. So we started a brand new program, first time ever done in Texas, and that was called the Emergency Department Telehealth Program. We used our Ask My Nurse, which is a bank of nurses that do telephone triage. The patient would, rather than go to the emergency department, they would call Ask My Nurse. Ask My Nurse we had developed an algorithm with our emergency department team, and they went through a series of questions to determine if the patient actually needed to go to the emergency room, or could they stay at home and be seen by an emergency room physician in their home. It was a marvelous success. A lot of patients took advantage of it, the lower acuity EC patients, and we were able to do emergency care right there in the comfort of their home. The program is still going today, and it's been very beneficial for our patients. And we're able to keep about 70 or so patients out of the emergency department every month that don't really need to be there. Another thing we started working fast on was completely changing the total model of care for nursing and how we provided care in our clinics. We started integrating telehealth workflows, process maps, swim lanes, all of it, to the new way that we were going to deliver nursing care. We've talked about the My Health video and how the nurses got involved with helping the patients use that technology so that we could stay in touch. Pharmacy started a home medication delivery system that was amazing. And the patients had a choice at the onset if they wanted a video visit, if they wanted a telephone call, or if they wanted a My Health visit. If they wanted a video, telephone, whatever. There were the few patients that still needed to come in person because they didn't really meet criteria for telehealth, but most of them did. And we had over 1,000 providers participating at over 45 different locations. Next slide. This slide is very exciting. You can see in March at the very beginning, the number of telehealth visits that we had was pretty much zero. And then within 4 months, we were over 2,000. The graph just shoots up. We launched telehealth in our platform and ambulatory care service like a rocket going to the moon. We just blew it up, and the patients loved it, providers loved it. The nurses probably were the last to love it, because nurses, we like to see our patients and touch our patients. So I think the nurses took a little bit longer to adapt, but really amazing job by the entire team. Next slide. I wanted to share this with you because all of the massive things that we were doing in our platform and ambulatory care services were part of our communication plan. We quickly learned that what we were doing wasn't working. So I worked with our EVP and our project management team and our quality team, and we developed we call it a one-pager. And the name is actually stuck. We still use that word now all the time. I need a one-pager. And what that means is that we needed one page that we could send up to our executive team up at the system level to let them know what we were doing in ambulatory care services, how many patients we were touching, how many My Health visits do we have, how many telehealth visits do we have, how many calls, and then also give them a visual form. This really helped our system move fast, make decisions, and create a lot of good dialogue so everyone knew what we were doing in ambulatory care services. Next slide. We've talked a little bit about the navigation program, but I want to give you a little bit more detail on the amazing work that this team put together. This is a group of nurses that were working remotely with our COVID positive patients. 34 nurses were assigned to this program, and case management, patient education, and ambulatory nursing, but it was mostly our case management team and ambulatory. They worked 7 days a week, including the holidays. They took care of these patients. They called them daily, sometimes twice a day for 14 days. They advised them on their health. They checked how they were doing. They asked their temperature, how they were feeling, and helped them decide if they needed to go to the hospital or not. But they kept very close tabs on these patients, provided outstanding nursing care virtually for all of these patients, many hundreds and hundreds of patients this team took care of over the course of a year. The next slide. The Navigator program tracked our PUIs. We developed an Epic process, so we were able to track all of the activities electronically. We were able to implement multiple languages. We used our own employees for our own patients, and we were able to also track any daily exposures of our staff that maybe have contracted COVID while either screening or providing care in the clinics. Next slide. Here we go.
Okay, I think maybe Vivian stepped away. The polling question reads.
Oh, I'm sorry. I was on mute. I'm so sorry. I was on mute.
Okay, thank you.
True or false question. I've been talking my life away here. A patient navigation program was implemented to effectively track PUI individuals and connect the patient to seek clinical care as appropriate. So enter your answer into the chat box. True or false? So we do have answer in the chat box coming in. That is correct. The answer is true. So get back to you, Tony.
All right, thank you so much, Vivian. This slide is probably my favorite slide. I'm very excited to talk about this for just a few minutes. Our actual implementation and some key highlights here. Of course, we couldn't go into all of the detail, but I wanted to share with you what worked, what didn't work, and what we learned from our mistakes. first of all, we stood up clinics at Aldine Acres, Ben Taub, LBJ, El Franco Lee, MLK, Smith Clinic, Strawberry, and Thomas Street, because we quickly learned we could not vaccinate 100 patients in every clinic across the city. We needed to concentrate our efforts to partner also with limited resources on the pharmacy side. So what worked really well was working with our pharmacy team. We developed a process that at first a lot of people were very skeptical about, but the nurses said, just trust us, it's going to work. What we developed was a strong partnership where pharmacy would draw up the medication in the vaccine, label the vial, and then they would give that to the nurses in small amounts. So at each vaccine table, they might take 5 or 10 vaccines. So pharmacy was responsible for the transportation of the vaccine and the drawing up of medication. And there's 3 different logs we had to keep for COVID, and so maintaining all of those logs. And then the nurses were responsible in each clinic and were assigned to a vaccination station. And at first we assigned 2 nurses at the vaccination station, 1 nurse that would do the documentation and the intake, ask the patient the questions, and then the next nurse was preparing the patient's arm and getting ready to actually administer the vaccine. After the vaccine was administered, they did the teaching and the patient went on their way. By design, it worked very well. By design, we at first our goal was to do 28 vaccinations per station, setting up 6 or 8 vaccination stations per clinic. We realized in the first week that was not enough, that we needed to increase our efforts because the staff, it worked so well that the staff were actually much faster. They were able to give a vaccine anywhere from 5 to 10 minutes versus the 15 minutes estimation. So staff exceeded our vaccination goals, and we were able to do well over 1,200 vaccines a day. And then our mega site, El Franco Lee, we were able to do anywhere from 500 to 800 vaccinations a day due to the efficiencies and partnership with our pharmacy and nursing teams. I will tell you probably the most rewarding thing about setting up all of these clinics and being so successful was the gratitude of the patients. And all of you that have gone through the COVID pandemic, each one of you on this call could have your own story about your work environment and what you learned from the COVID pandemic. But one of the things I learned was how grateful the patients were when they would come to the clinic and get their vaccines and literally cry. They were so happy and so grateful. And one gentleman broke out into a song and he started serenading the nurse. And she said, "What are you doing? What are you doing?" He said, "I love you so much. I'm so grateful for this vaccination. You're saving my life. I want to serenade you as you vaccinate me." And so he sang, he had a very beautiful voice too, and he sang to her while she gave the vaccine. Very rewarding experience. Next slide. So continuing on with our efforts, we developed the house calls, the homeless program, as I mentioned. We started vaccinating our patients when they would come to outpatient visits as well as primary care visits. We started the Friends and Family program, and this slide's a little outdated. At the time, we did over 130 COVID vaccines, but now we're way over 200,000. And I will tell you that now, being at Ben Taub, we have started vaccinating our patients in the emergency department, and we just recently started vaccinating our patients on the inpatient side. So our inpatients in the hospital are now getting vaccinated. Next slide. We have partnered also with the City of Houston during all of these efforts. And we've been able to give first and second doses at one of our clinics. We've given 1,200 vaccines and also at Settegast and Gulfgate. And another big endeavor was the vaccine allocation, or how we were going to transport these to all of our clinics, the staffing that we've already talked about, but also reporting it in M-Track. We had a small army of nurses in the background putting all of these vaccines in M-Track, which took them countless hours to report these vaccines. Next slide. Towards the middle of the pandemic, we developed a ambulatory-wide COVID-19 immunization dashboard. And just to highlight this, with this incredible tool that we continue to use today, but it's how many immunizations were given at Harris Health in all 3 pavilions, but most of these all of these came from ambulatory. And then as you can see down there on the bottom left, by clinic, we could monitor in real time, this thing would update every 10 minutes how many vaccines were given at that clinic. And then that would roll into the grand total. And we could track all throughout the day if we were hitting our goal or not. And that enabled us as leaders to shift resources. If all of a sudden one of our clinics was slowing down because they had a couple of staff call in or somebody got sick and had to leave, we could go to the tracker and we could see, okay, well, this clinic is going a little bit slower, so we can mobilize that staff over to the other clinic. And it just worked extremely well to help us manage in real time the operations of the clinics. Also, onto the right, the red, the pink, we could also monitor our appointments. So once we gave that first vaccine, we went ahead and scheduled them for their follow-up appointment for their second dose. And then my last slide, next one. I put this in here because we were at the very beginning of the pandemic, starting from the very beginning, we were mobilizing our flu campaign, and we were trying to vaccinate 217,000 patients with the flu vaccine. And this was we set up a drive-by flu campaign, and you can see that those 5 clinics right there, they could schedule their visit and drive through these locations and get their flu shot. This was a massive endeavor. It was countless hours and planning. And the reason I bring that up is we had to make a very tough decision in ambulatory. And I remember meeting with my boss and a small team, and we had to decide, were we going to continue with the flu campaign, or were we going to switch gears and divert resources over to the COVID pandemic? And this was early on, and we didn't really know the best decision, but we talked to our experts and we got with our teams, and we decided to slow down on the flu vaccine and focus all efforts to COVID vaccine. And I'm really glad we did. It was the right decision. We continued to give our flu shots, but mobilizing 100% of all of our available resources, we've been able to successfully vaccinate several 100,000 patients in Harris County. And that's one thing that I'm most proud of ever in my nursing career. So thank you very much, Vivian, for letting me share a few highlights.
Thank you very much, Tony. Do we have any questions for Tony from the audience? So thank you very much. And it's you know, I am also working at Harris Health System as well, and just attending, you know, watching Christine and Tony presenting this give me a lot more information in how, you know, leadership and teamwork and experts, you know, come together to in this responding to the pandemic, and then also is not lose sight of the patient that we serve. You know, we are in healthcare for a reason, and that reason is to serve. So again, thank you so much for your experience, sharing with us your leadership, you know, your hands-on experience, taking us through. And I hope that attendance in the, you know, the folks in attendance today can bring back and share with your folks or your hospital system, you know, something you learned from today, and keep that patient safety and quality at the center of everything we do. So with that, I know Kim Rogers, one of our educators, has a couple of instructions that she wants to highlight for you to submit to claim the CE that is offered for today. Kim?
Vivian.
Okay.
Yes, ma'am.
I just wanted to say, before Kim says that, I just want to say that I'm proud of the work that we did at Harris Health for all the efforts we put into this pandemic and all the great work that all the teams worked together. We came together as a system, and everybody worked together, and we made it through this phase of the pandemic, and hopefully we see the decrease in the patients being admitted. So hopefully we're on the downward side of this, but we still have to keep in mind, you know, that it's not over, and, you know, it could spike again anytime, but we're ready and we can remobilize and start this over again. Hopefully we don't have to, but we have the processes in place. We put it together, so we have the processes to make it easier for us to do it over if we need to.
Yes, well said, Jerry, well said. Any other comments from the audience?
Yeah, my name is Lily, and I'm actually a retired infection preventionist, but I also had, I did work at the quality department many years, and I certified in healthcare quality also. And I'm so impressed by the Harris County and everything that the Harris County has done in our state. I'm really impressed. It's been really wonderful, and I'm so proud that I live in the Harris County. And although I'm not really practicing anymore, but I keep up with the things. And everybody, all of you have done a great job. It's really, we're proud to be living under the care of all the Harris County and the commissioner and everybody. It's been wonderful. Yeah.
Thank you so much, very much, Lily, and such a devoted retiree. I know many of us in here want to learn more, and we take our 1 extra hours on the Wednesday evening away from our family and dinner. Of course, it's just us and dinner here to learn more. So I'm very thankful for your continued commitment, engagement to learn and keep up. So thank you. And I hope that someday you can come and share your experience while you were practicing with the rest of us too. So that's the whole idea from our association, is to share that knowledge and then continue to learn.
Thank you. I'm one of the oldest members of Texas Golf Course. I used to go to the meetings in early 80s. So
wow, thank you very much. Thank you very much.
Yeah.
Okay, any other comments from the audience? All right, Kim, instructions to claim. Okay.
Vivian, I just wanted to say thank you for hosting, and thank you for the nice introduction and facilitating, and it was a very nice experience. So thank you, Vivian, for putting all this together.
Thank you, Tony.
Okay. All right. I just wanted to reiterate that in order to obtain nursing continuing education credit, you must attend the entire webinar. Attendance is based on login time, log out time, and poll participation. So within a week or two of this event, you'll receive an email from the CEU Institute with a link to complete an online form. This form must be completed and submitted within 72 hours in order to receive your certificate. That's it.
Okay, thank you very much. So look forward to check your emails, the emails that you entered to register for the webinar. There will be a form sent to you, and you to submit that form back to us within 72 hours to receive the CEs. Again, thank you very much for everyone's participation for tonight. And we are going to have another webinar occurring in July. So I hope everyone mark your calendar and register for that as well. It is also free to members, and we will see you then.
Thank you.
Have a good evening. Thank you.
Thank you.
Thank you.
Good night.
Okay, we're fine.
Thank
Thank
you,
you.
Vivian.
Thank you all.
Good night, all.
All right.